Okay, so we can't wait for so long. I think two more students have to come, right? Maybe let them join back. So I hope you know about this particular subject. Like it is a 2 credit paper, and you will be having only theory exam. You don't have OSPE in this particular subject, but you have a assignment and you will be having a presentation. Okay, so you will have medicine, assignment, presentation, and final exam. So in this presentation part, I will be taking up, and other two, Dr. Deepthi will be taking up. Is that clear? So now today's class, if you see, we will be seeing about the anatomy aspect of the reproductive system. Uh, okay, anatomy of the reproductive system. So in that, if you are here in the campus, then we would have we will take you to the anatomy FOM lab, that is FOM clinical lab. Then we will be showing you the manicures. We will be able to teach you how to palpate and other things. But since we are having online classes, I will show you the videos of how, what is the reproductive system, how to palpate the pelvis, what are the different types of pelvis, all those things I'll show you the videos. Exactly. So first class, we may not have much interaction because it is full of the video and video explanation. Is that clear? So from next class, I will be talking more with a little part of video, but today's class there will be more of videos. Okay, so we will go to the first video, that is reproductive introduction to the reproductive system. So in this, if you see, I have taken a video of I have taken a video of how the reproductive system is, where it is positioned, so how it is fixed, what is the ligament, all those things. Is that clear? So we'll go into the video. I think you're able to hear the voice as well as the picture, right? Somebody please respond.
Yes, Miss.
Okay.
Miss, but the audio is not clear.
You're not able to clear the volume, or
yeah, not able to clear the video volume.
It is maximum only. I've kept in 100. Now?
No, Miss. So you can see the location of this.
Yeah, a bit better.
Yeah. The bladder and the digestive system behind it. So the main parts that I'm going to talk about are the ovaries, which are the final female sex organ. And then you've got the fallopian tubes. homogeneous population. So the ovaries are actually suspended and have several wrinkles. I'm talking about this here. The ovaries are intraperitoneal and they release the egg. Cervical vertebrae, so it just refers to so I've just switched over to a simple cross-section and I've just used to show you the external
So, as a physiotherapist, we don't need to go very in detail of all these structures, but we need to know how the structures are present so that when we learn about the condition, it will be easy for us to understand what is happening in the condition, what is the cause of the problem, and how to solve the problem. Okay? So here, main thing, like one point I want to stress is you need to see the position of the uterus. So position of the uterus will be in the anteverted position. So it will be like it will be just behind the bladder, and the upper part will be coming above the bladder like an anteverted one. Then slowly when the mother is getting pregnant, this anteverted uterus will be lifting up and it will be pushing all the structures. Is that clear? So this is just for you to understand what are the structures and how it is present and other thing. So next we will see about the pelvis, because like these three are like smooth, like this reproductive system is a smooth muscle and it will be just present inside the pelvic organ. So the pelvic organ is a outer pelvis, that is a hard bony structure. So the hard bony structure will be holding all the smooth structures inside the particular cage. Okay, so I'll show you about the pelvis now. If you can't hear or anything, you just let me know, okay?
Pelvis.
This is termed as pelvic girdle because it creates access system. So here in this lecture, I'm going to read about the various aspects of pelvis, which there are bones, joints, ligaments, diameters, relationship to the fetus. So let's have a look at the bones. There are the two hip bones, which is formed by the ilium, ischium, and femur. So first we talk about ilium. Ilium forms the flat flap which is present on the superior aspect, and its superior border is formed in iliac crest, which ends at the sternum and serves as anterior superior iliac spine, and its main flap is medial spinous anterior inferior iliac spine, and posteriorly as iliac crest and a posterior superior iliac spine, and lower ends posterior inferior iliac spine. And there is a notch on the posterior aspect, and this notch is termed as greatest sciatic notch, for which the greatest nerve in our body, that is sciatic nerve, passes. On the posterior aspect, there is a different area, and it is termed as iliac capacity, and it is part of the last of the base. The medial or the anterior surface forms a depressed portion, which is termed as iliac fossa, and inferior to iliac fossa is one line which runs superiorly or anteriorly, and it is the arcuate line. Later on, it has got clinical significance because it forms a part of the anatomic pelvic. Medially,
Isma Renuka Devi, do you have any doubt? Yeah, I have uploaded the videos in the LMS.
there is an articulating area in this ilium which articulate the sacrum and form the strongest joint in the body, that is sacroiliac joint. This ilium has got two parts. The superior part is termed as ala, and the inferior part is termed as body, which attaches with the ischium. So the next part comes the ischium. Ischium has got two parts: the body, which consists of the different portion, and it is termed as ischial capacity, and superior to that is or anterior to that is the ramus, and this ramus and the pubic bone form a opening, and this is termed as obturator ramus, which is covered by the obturator membrane, which consists of the process. Posterior to ischium is one projection is there, and it is termed as ischial spine, and it has got clinical significance, for which cavity has dislocation of neck. The anterior big bone is flanked by the big bone, and the big bone has got three parts: the superior ramus, the inferior ramus, and the body part. The body part where the two ramids are meet together. The anterior border of the chest. Slightly lateral to that is pubic tubercle, and from pubic tubercle there is a line which runs posteriorly or laterally is the pectineal line, which later on merged with this arcuate line and formed ilio-pectineal line. Together, the three bones, hip bone, that is the pubic, ischium, or ilium, forms a cup or socket-like structure. And this is the axial bone. And this is a socket-like structure for which the head of the femur is attached or articulated to it, so that it can easily move in any of the direction. for which you plan to use it, and the anterior portion, which is formed by the two pubic bones. Then comes the posterior aspect of pelvic bone, which is the part of axial skeletal system, that is the sacrum. And the sacrum is a triangular shaped bone, and the sacrum is formed by 5 loose vertebrae, and the anterior border is smooth and firm, and the female is more or less wider or shorter. Posteriorly, it is more rough in area because it gives attachment for the various muscles. The superior broader part of the sacrum is termed as base, and the inferior narrow portion is termed as apex. On this superior part, there is anteriorly projected structure is termed as sacrum. And posteriorly, there are two articulating surface area which attaches with the lumbar vertebra and forms the sacral joint. On the lateral aspect, there are two follicular shaped structure which extends laterally from sacrum and these are termed as sacral arm. Anteriorly, there are 4 transverse lines, and these transverse lines showing the fusion of vertebral bodies of sacrum, and at the end of this transverse line, there are the 4 pair of anterior foraminals, and these foraminals are continuation with the posterior foraminals, to which blood vessels called enter or exit. Posteriorly, on the middle aspect, in the sacrum, there is a sacral crest, and it is formed by the fusion of spines of the sacral vertebrae, and it gives attachment for the ligaments or the muscles. At the apex part of the sacrum, there is a hole, and it is termed as sacral icus, and it is continuation with the sacral canal, and the sacral canal is attached to the vertebral column. And on the either side of this icus or opening are the 2 projections, and it gives attachment for the ligaments to connect with the coccyx. So it is a triangular shaped bone. It forms a part of axial skeletal system which connects the sacrum with the ilium and forms the strongest joint, sacral joint. Lower to that is a triangular shaped bone which is termed as coccyx, and it is formed by 4 loose vertebrae, and this coccyx is attaches to the sacrum by a sacral joint. So the broader part of this coccyx is termed as base, and the pointed end portion is termed as apex. On the posterior aspect, there are the posterior cornea, and these cornea attaches to the ligament, the sacrum, and the female is connected inferiorly, and this joint is more flexible in female so that fetus can easily pass through it. So here in this model, we are seeing the bones, and the bones are the pubic bones, ilium, ischium, and posteriorly there is the sacrum. Now comes the joint, and joints are divided when 2 bones meet together. There is one is the flexus pubis, and it is present in pubic bone. Then sacroiliac joint. So the artery, the sacrum, and the ilium on both sides is the strongest joint in the body, sacroiliac joint, and this sacro-occipital joint, which is more flexible in female, as it provides room to the pelvic outlet so that fetus can easily pass through it. Next comes the ligaments, and these are the structure which helps the joint together. Interpubic ligament, which attaches or which is present in the pubic bone. This sacral cartilage is present. There are various sacroiliac ligaments which are present on the anterior and posterior aspect, which help the sacroiliac joint together. There is sacro-occipital ligament which attaches the sacrum to the coccyx, and is also present on the anterior or the posterior aspect. spinal on the these are the areas. There is very limited movement in between the joints in non-pregnant state, but at the time of pregnancy, these are hormonal causes contributes to the cycle and increases the moving down of the pelvis so that these can easily rotate the pelvic in a hand. It can easily pass through. Next comes the distance between false pelvis and true pelvis. In false pelvis, there is no exact pelvic measurement and it is bounded posteriorly by the lumbar vertebra, laterally by the iliac crest and iliac fossa, and anteriorly by the mitral and abdomen. So we can't measure it precisely, but it is supposed to leave us at the time of pregnancy. But in the true pelvis, it has got the exact pelvic measurement and it has three parts, that is the pelvic neck. So I'm pointing lumbar, focus, area is termed as the pelvic rim or the inlet. Then comes the cavity and it is round structure and forms the curved canal. And the last small region is termed as pelvic outlet. First we deal about the pelvic rim or the inlet. This is the area where the fetus come in contact with the womb pelvis. There are various bony lines on this, and these are termed as lambda. So from anterior to posterior, there are the 9 lambdas, and these are upper border of symphysis pubis, pubic crest, pubic tubercle, pectineal line, pectineal ligaments, pectineal line, sacroiliac joint, anterior border of scapula, and the sacral trochanter. So these 9 landmarks are seen both sides, and this area is termed as pelvic rim or inlet. The next comes the pelvic cavity, and it is round structure. It is bounded above by the pelvic rim and below by the obstetrical outlet. And the last moving part is the pelvic outlet. So here we'll discuss about the diameters of these all three parts. So in pelvic rim, there are the three diameters. These are anterior posterior diameter, transverse diameter, and the oblique diameter. So in the anterior posterior diameter, there are the main three diameters, and these are two conjugate, or you can say anatomical conjugate, the obstetric conjugate, and the gyneco conjugate. So first we need the true or anatomical conjugate. This is the distance between the midpoint of sacral trochanter till the upper border of symphysis pubis, and this measures about 11 centimeters. Then comes the obstetric conjugate, and the obstetric conjugate is the exact space available for the fetus to pass through the rib and enters into the pelvic cavity. So this point extends from midpoint of sacral trochanter to the midline of symphysis pubis, where a projection is there in the middle till the point is ended. So this distance is about 10 centimeters. Next comes the diagonal conjugate, and this is the distance from midpoint of sacral trochanter till the lower border of symphysis pubis. So it is about 10 centimeters. So this diagonal conjugate has got significance because it carries the measurement of diagonal examination. The next diameter of pelvic rim is the oblique diameter, and these are the two right and left. Right between the right side and the left side, and it starts from right side to left side till the opposite side of the pelvic elements is the left side. So it is about 10 centimeters, and the left pelvic diameter extends from left side of the ideal pelvic elements. These are the same side, left and right. The third diameter is transverse diameter. The transverse diameter Here, duct is formed by sagittal pockets, which is curved and is formed by its anterior diameter extends from the junction of second particular sagittal vertebra illness till a midpoint of suffices for it. It is the midpoint of suffices for it, and it is usually found falciparum. Its transverse diameter or having a not position exactly on its back is not measured. So we can say that the lower arm diameter of the handicap is about falciparum. Its curves belongs to palm, that is, at the outlet, which have conjugates and they have oxidable conjugate and conjugate conjugate. And oxidable conjugate, there are four diameters. Noble water of the foot, so it is calcium directly, and it is about 11 centimeters. The transverse diameter of oxidable conjugate is 9 times 9, and it extends in between the two ischial spines, and it is about 10.5 centimeters. In the true or anatomical conjugate, the anteroposterior diameter extends from the tip of pocket till the lower quarter of the pelvis, and which is about 28 centimeters, and its transverse diameter extends in between the inner quarter of the sternum and about. So the oxidable conjugate has an immediate importance because the area so here in this video, we have seen the practical aspect of maternal pelvis, and this pelvic bone forms a bridge between the axis and the axis these three bridge-like structure is create contact between the axis and the pelvis and also connects between the sides.
Okay, so I hope you understood a little bit about the anatomical structure or aspect of the pelvis. So, like, why it is more important for in female means like it is holding the important structure, your uterus. Like throughout the pregnancy, it is very important. Not only that, for the birth of the baby, this is very important. And with the help of the hormones, this pelvis will be little bit will become little loose and it will elongate so that the baby will be coming out of the pelvis. So here we there is definitely a difference between the male pelvis and the female pelvis. So the female pelvis will be little broader. That's why most like all the females have a broader waist, and this difference is just to help during the pregnancy and to help during the delivery. Okay, so now we will see what is the difference between male and female pelvis. I think in this video itself they have covered the diameters of pelvis, so I'm not going to show you again another video regarding diameter of pelvis. If you have any doubt, then you can see it from the LMS video. Okay. So in this video, they will clearly show difference between each pelvis. So especially if you see there are 4 types of female pelvis. In that 4 types, only the gynecoid pelvis is the actual female pelvis. So here they are explaining about this gynecoid pelvis and the male pelvis. So they will be showing you both the male pelvis and the female pelvis, and they will show you the difference, and they will show you the comparison. Okay, so now I think you would have understand why there is a vast difference between male and female pelvis. So in case of female pelvis, it has to hold the uterus throughout the pregnancy, and after that, it has to bring the baby out. So that's why there is a vast difference between male and female pelvis, and female pelvis is completely designed for this. So that's why the curvature, the sacral curvature, the sacral curve will be like a cup, so that it has a wider backside, and it will be more flexible only during the pregnancy. And definitely, because of this flexibility and because of the changes during pregnancy, the women definitely will have a lot of problems, and as a physio we will be dealing all this particular problems. Okay, so I think we will go with one more video. So in the second video we saw how we were seeing about the pelvic outlet, inlet, and we she told something about true obligate, and what is wider pelvis, what is a narrow pelvis, and all those things. So I'll show you another video how to palpate this one. So how to palpate in a woman, how to palpate and find out whether she's having a wider pelvis or a narrow pelvis, whether she will be able to deliver normally or she will have some problem. So usually the gynecologist will be doing all this palpation before delivery, so that they can come to a conclusion whether to go with a normal delivery or to go for a cesarean section. Okay, so this is the normally the gynecologist will be doing this particular palpation. So as a physio, it is good enough if you just know about the palpation. So I have not uploaded this video in LMS. I will do after this class. Okay. Just a So here they will be demonstrating using the manicure how we have in our FOM clinical skills lab. So same manicure they will be using, and with that only they are going to explain it.
Hello, I'm Chris Borowski. I'm an educator. Thank you for taking the time to watch this video on clinical health imagery and basic female health effects. Goals and objectives of this video are as follows. Briefly review the basic public policy as it relates to imagery. Describe mission introductory techniques for relevant portions of clinical health imagery while maintaining patient comfort. Introduce the four basic female health effects and apply knowledge of clinical health imagery to the findings specific to each health effect. Okay, so first we'll start with some very basic bony anatomy of the pelvis. The three bones of the abdomen and bones are the ilium, the ischium, and the pubis. The pubic bones are the endemic articles of the symphysis pubis anteriorly, and the clades are made of the sacrum articulate posteriorly. Two bony projections are important when discussing clinical health imagery, and these are the two spines, which can be seen on the inner medial aspect of the tissue. Next, gel applies the index and middle fingers of the gloved hand, which is gently placed into the vagina. The wrist is dropped. The examiner palpates the anterior to examine the guilt staple comes right with the middle finger. This allows a sense of pelvic inlet and the anterior posterior diameter of the pelvis. For a normal or wide AP diameter, the sacral promontory will not be reached. For a narrow AP diameter, the sacral promontory will be raised with the middle or even the index finger. Next, the hand is pronated 90 degrees. The curvature of the sacrum is palpated by moving the fingers inferior. The anterior surface of the sacrum is described as being hollow and flat. The midline of the pelvis is examined next by slightly removing the fingers from the vagina, palpating it forward and the hip line of the pelvis. The spines are described as prominent and patterned. At this point, generalized assessment of the bispine system is mediated, which is helpful in assessing if the transverse plane of the pelvis is wrong, wide, or neutral. From the ischial spines, the slope of the pelvic sidewall can next be assessed. This can be done directly by moving the internal index finger against the ischial spine and palpating the ipsilateral ischial tuberosity with the thumb. The tuberosity is the lateral of the spine. This is a diverging pelvic sidewall, and the tuberosity is the spine. This is called parallel sidewall. And the tuberosity is called a converging pelvic sidewall. The pubic angle is not pubic arch. That is described next. In examining the retropubic angle, the examiner reaches the two examining fingers up behind the pubic bone and palpates the posterior aspect of the pubic bone, the superior pubic bone. This will allow assessment of the anterior portion of the pelvic inlet. The retropubic angle is described as wide, round, narrow, or angulated. Finally, the subpubic arch is examined. This can be performed by palpating the inferior aspect of the pubic bone and estimating the arch is about 110 to 120 degrees wide, greater than 90 degrees, less than 110 degrees, which is normal, or less than 90 degrees, which is narrow. This is the final assessment of the pelvic outlet. In 1933, Colorado Boy developed a classification system for the four basic female pelvic types. They are the gynecoid, android, anechoid, and cladoid pelvic types. The gynecoid pelvis is the most common pelvic type, representing approximately 50% of all pelvic types. The gynecoid pelvis is round, spacious throughout, creates an overall cylindrical shape that favorably allows the anterior rotation of the fetal head. This pelvic type is the most favorable for vaginal birth.
So this is like about the four types of pelvis, like four types of female pelvis. Okay, so this is not about the male pelvis, okay?
A clinical pelvic, the round pelvic inlet of the gynecoid pelvis is associated with sacral promontory, not the and a right sacrum is long. The ischial spines are not round. The pelvic sidewalls are parallel. The subpubic arch approaches 90 degrees, and the right is normally greater than 4 level. The android pelvis is present in approximately 25% of women. The android pelvis is the most restricted of all pelvic types, owing to the limited space on the inlet and the progressive buckling of the mid pelvis in the pelvic outlet. Arrested descent is most commonly seen at the level of the mid pelvis in the android pelvic type. On clinical pelvic exam in the android pelvis, the pelvic inlet is triangular in shape. The diagonal edge is narrow, and the retropubic angle is sharp and acute. Sacral is long, always middle curve. The ischial spines are prominent. The pelvic sidewalls are convergent. Superior arch is narrow, as is the right tuberous distance. Android pelvic type is found in approximately 20%. The anterior posterior diameter is much wider than the transverse diameter. Few that often only engage the pelvic inlet. The occipital posterior position and usually does not rotate. The spacious posterior pelvis accommodates the OP needle head, and these infants can be delivered easily from the OP position. On clinical telemetry, the pelvic inlet of the upright pelvis is fully shaped, the diagram matching it and the retropubic angle perfect sharp. The bispinous distance is narrow. The double sidewall is narrow. The suprapubic arch is less than 90 degrees, and the bituberous distance is more narrow. The plateauing pelvic type is only found in 5% of women, even though it has the most stable. The transverse diameter is very wide, and the AD diameter is very narrow. Needle head often has to engage the pelvic inlet with the transverse diameter. Rotation of the needle head does not then occur until the head is on the perineum, and pelvis transverse rest is not. On clinical telemetry, the sacral promontory of the plateauing pelvis is reached, and the retropubic angle is near the pelvis. The sacrum is posterior and more flat. The spines are wide, and the pelvic sidewalls are divergent. The subpubic arch is wide and flat, and the bituberous distance is very wide. There you have it, clinical pelvimetry classification of case of female pelvic types. With a little bit of practice, you'll be able to identify the landmarks of the female pelvis and start to practice clinical pelvimetry. With a little more practice, you might just identify your first plateauing pelvis. Always allow your patients.
Okay, so maybe the video was little faster. If you were not able to understand, go through the video again slowly, maybe to your pace. And if you have a pelvis, then you can palpate and see the structures. Then it will be easy for you to understand. That clear? So the other two videos I'm not going to go today, because if too much video, then it will be like you won't listen it. I know that. So we will be seeing both the videos when we are seeing about the urinary dysfunction. So those two videos are related to pelvic floor. So we will be using, like we will be reading about pelvic floor at the last. So we will see when we are seeing about the urinary dysfunction, and that time I will show you this anatomy of the pelvic floor. Then we will continue with the pelvic floor dysfunction. So that will be more appropriate. Now if I show, you may not, like you may forget when I'm teaching the actual urinary incontinence thing. Is that clear? So we will see that at the last. So for today, do you have any doubt? Actually, go through the slides. Along with that, you just watch the video so that it is easy for you to understand the theory. If you read it separately, then you may not understand. So you have to correlate both the video and the theoretical slides so that you will be able to understand more clearly. Is that clear?
Yes, Miss.
Okay. So I think like, do you have any additional students from batch 21? Two more students are there. Totally, how many students will be taking our women's health? 9 students from 23 and 1 student from batch 21.
Yes.
Okay. So I'll just leave the remaining class to Dr. Deepthi. Or like, I'll give you some more time. Do you have, you can just go through, and if you have any questions, you can ask me. Okay, since like it is only an introductory class, we have seen only the videos. So from next class, we will have the physiotherapy role. So we will have more into our subject. So seems to be a little bit vague because this is anatomy. So from next class, it will be a little more interesting. so that we will be able to apply our techniques and we will be able to correlate properly. Is that clear?
Yes, Miss.
So I'll wait till Dr. Deepthi logins, then I will leave the class. Okay, maybe in another 2-3 minutes she will log in. Whether the video was clear at the later part, maybe at the end only it was little in the middle only it was little bit slurry, right? The remaining time whether the video was clear.
Yes, Miss.
ஹலோ இப்போ நான் வந்து என் பண்ணுமா இல்லை லாகின் என்ன பண்ணும்?